Hey everyone, my name is Faustine Ramirez and I'm a master tutor with MedSchoolCoach. Today I'll be reviewing a Step 2 CK question. So let's start by reading the STEM. A 2-week-old infant is brought to the pediatrician's office for an initial examination. She was born at home at 38 weeks gestation to a 26-year-old primigravid woman. The parents have no medical problems and the pregnancy was uncomplicated. They are concerned that she has difficulty latching when she breastfeeds and takes a long time to feed. She does not wake up regularly for feeds every 2 to 3 hours. Vital signs are within normal limits. Weight is in the 74th percentile, length is in the 48th percentile, and head circumference is in the 92nd percentile. On examination, the infant has large, soft fontanels, a large protruding tongue, and her face appears puffy. She has a hoarse cry when she is unswaddled. Her skin is jaundiced and slightly dry. Cardiac examination is unremarkable. The abdomen is soft, non-distended, without hepatosplenomegaly. She has a small reducible umbilical hernia. Her suck is slightly uncoordinated, and she has mild hypotonia. Which of the following is the most likely to have predicted these findings? So I'd like you to pause the video for a moment and try to work through this question on your own first. All right, welcome back. So let's approach this question together. So the first step is going to be to read the very last question, to read which of the following is the most likely to have predicted these findings. So we are identifying what the purpose of this specific question is. And so this is going to be the type of question where we need to identify the diagnosis while reading the STEM, and then be able to answer a specific question about the diagnosis. And here, the specific question about the diagnosis is how we could have predicted these findings or predicted the diagnosis. And so then we glance at the answer choices very quickly and we see that they all involve some form of either prenatal or postnatal testing that is typically done routinely in pregnancy or in routine newborn care. And so looking at all of these, there are a lot of different types of screening tests that are performed either in the first trimester, the second trimester, the third trimester, or even in the newborn period. So we'll have to be able to really specifically identify which test is appropriate to predict the diagnosis. And so then we only take a few seconds to review these. This helps us frame how we're thinking about this question. We know that we need to identify the diagnosis as we're reading the STEM. And so let's go to the STEM and read from the top and highlight the key elements. So a 2-week-old infant is brought to the pediatrician's office for an initial examination. She was born at home at 38 weeks gestation to a 26-year-old primigravid woman. The parents have no medical problems and the pregnancy was uncomplicated. So one thing that jumps out at me here as we're reading is that this infant is being brought to the pediatricians for the first time at 2 weeks, and she was born at home. And so whenever you read something similar to this, she was born at home, or potentially she was born in a different country and you don't have any information about the prenatal course and the pregnancy history here, we're not really told whether or not the mother got prenatal care. We're just told that the pregnancy was uncomplicated. So when you hear this, it's not always true, but you should already be thinking that there's a possibility that the mother did not get all of the prenatal screenings that she would necessarily have gotten if she was having her routine prenatal visits at every single visit. And you should also be thinking that potentially the newborn, if the newborn was born at home, did not get all of the elements of routine newborn healthcare maintenance that babies would get if they were born in the hospital. And so when you see these types of phrases on boards questions, you should already be thinking about potential screenings or healthcare maintenance things either during the pregnancy or in newborn care that were not potentially not received. And this isn't necessarily true in real life, but on the boards, that's one way for them to hint at the fact that there might be some routine healthcare maintenance items that are missing. So for babies that are born at home, you should be thinking whether or not the mother received all of her prenatal screenings, and also whether the baby received the routine healthcare maintenance items that newborns get when they're born in the hospital. So then we'll continue reading. The parents have no medical problems. The pregnancy was uncomplicated. They're concerned that she has difficulty latching when she breastfeeds and takes a long time to feed. She does not wake up regularly for feeds every 2 to 3 hours. And remember that infants should be waking up in the newborn period every 2 to 3 hours to feed. Vital signs are within normal limits. Weight is in the 74th percentile, length is in the 48th percentile, and head circumference is in the 92nd percentile. On examination, the infant has large, soft fontanelles, and a large protruding tongue, and her face appears puffy. She has a hoarse cry when she is unswaddled. The skin is jaundiced and slightly dry. Cardiac examination is unremarkable. The abdomen is soft, non-distended, without hepatosplenomegaly, and she has a small reducible umbilical hernia. Her suck is slightly uncoordinated, and she has mild hypotonia. So before we move on to the question and the answer choices, let's take a moment to synthesize these findings. So for these pediatrics questions, where there are a lot of different physical exam findings, and they're most likely getting at some form of syndrome or condition with multiple different features, I think it's helpful to either in your mind review these or jot down a few things to try to pull apart the most important elements of the presentation. So the most important elements from either the history and or the physical exam, and try to put these pieces together and see what the constellation of findings looks like. And taking that step back allows you to synthesize these findings, to look at the overall constellation of findings and be able to identify what that constellation corresponds to, which diagnosis or which condition, which syndrome. And so I think this is particularly useful for long stems as well as pediatrics questions about different syndromes, because they often have a lot of different findings. And so putting them together like this helps you take a step back and identify what the diagnosis is. So let's start from the start. So initially, we're told that she has difficulty latching, takes a long time to feed, and doesn't wake regularly. So I would call this feeding difficulty or feeding intolerance, depending on what the description is, but big picture, feeding difficulties. Then we go on to the growth parameters, and the weight and the length are still normal percentiles, but the head circumference is increased. And we see that the birth weight is, or the weight here is slightly larger than the length. So far, if we're thinking about genetic syndromes, these first two findings are very nonspecific. They're consistent with the fact that this is some sort of syndrome or, congenital condition, but it doesn't give us much more information than that. So these are nonspecific findings that we see in a lot of different pediatric syndromes. So let's keep reading. Then we're told the infant has large, soft fontanelles. Remember, fontanelles should be open, soft, and flat. They should not be bulging, and they should not be, because bulging would be a concerning sign for increased ICP. They should not be sunken because that would be a sign of dehydration. So soft and flat is normal, but these are described as being large. So that would be abnormal that they mention that. There must be a reason for them to mention that. So large fontanelles. Large protruding tongue, another term for that is macroglossia. And her face appears puffy. So not 100% sure where they're going with that yet, but we can write it down because it must be important here. That's not a normal finding. There's also a hoarse cry. And there's jaundice. Now, in a 2-week-old, we would expect that physiologic jaundice would have resolved already. And so at 2 weeks here, still having jaundice would be considered a little bit prolonged. We're also told that the skin is dry, and that could be a totally normal finding, but in the presence of all of these other features, we get a sense that it's potentially part of the constellation of symptoms, especially given there's so many other things. If it was just a little bit of dry skin, that might be normal, but here with all these other features, I think we should pay attention to it. Cardiac examination is normal, abdomen is soft, no hepatosplenomegaly. That's important when we're thinking about newborn constellation of findings. Newborns with a lot of different findings, you should be thinking about congenital infections. And so remember that a lot of newborn infections will have jaundice, hepatosplenomegaly. So if we're seeing a congenital syndrome or constellation of findings in a newborn with jaundice, we should be looking out for other things like maybe a blueberry muffin rash or hepatosplenomegaly that could clue us into a congenital infection. Now, we don't have hepatosplenomegaly, we don't have a blueberry muffin rash here, so that makes me lean a little bit away from a congenital infection, although it certainly could still be on the differential. And finally, a small umbilical hernia. and the suck is uncoordinated with mild hypotonia. Those go hand in hand. If the infant has poor tone, she'll be less likely to be able to have a good sustained suck, and so those go hand in hand. So things to me that are non-specific when we're talking about congenital syndromes or newborns with a lot of different findings where we're concerned about some sort of syndrome or constellation of findings. So the feeding difficulties, the increased head circumference, those are pretty non-specific. The hypotonia, also non-specific. Prolonged jaundice, if you're thinking about a congenital infection, a lot of congenital infections do present with jaundice. However, here, I would say that prolonged jaundice is one of the characteristic features of this syndrome. So even without these first two that are nonspecific, if we look at all of these together, especially with these bullet points here, large fontanelle, and these going downwards, which are even more specific, this constellation of findings is classic for a specific pediatric syndrome that you should be able to recognize. And so putting all of these pieces together, when we see them like this, what really strikes me is that all of these features are really classic for congenital hypothyroidism. And so congenital hypothyroidism, and we'll learn a little bit more about this next, but congenital hypothyroidism is definitely a more challenging diagnosis to be able to identify, but after this question, I'm confident that you'll be able to identify it. And these features here with the macroglossia, the puffy face, dry skin is classic for hypothyroidism. That's true both in infants and in adults. You can also get constipation, although that wasn't mentioned here. But some of the more specific findings for congenital hypothyroidism, as we'll discuss next, are the hoarse cry, the prolonged jaundice, the hernia, and the macroglossia, as well as the large fontanelles. Now, we'll learn about congenital hypothyroidism, and what we'll learn is some of these features and about the diagnosis. So looking at some of these answer choices, this really depended on your ability to identify this syndrome and then to know that this syndrome could not be predicted by any prenatal screening. And so then we look at these answer choices and we can cross out the ones that are all referring to prenatal screening because we know that congenital hypothyroidism is not something that can be picked up on with the routine newborn screens. So the prenatal ultrasound, for example, the anatomic survey at 20 weeks could pick up some other syndromes or other congenital abnormalities, but congenital hypothyroid is not one of the ones that it would pick up on. So we can cross that out. Maternal glucose tolerance testing in the third trimester, this could potentially predict other abnormalities that are associated with maternal hyperglycemia and poor insulin and glucose control. And so if you don't remember which findings are associated with maternal hyperglycemia and poorly controlled diabetes in pregnancy, now's a great time to do that. We don't have time to do that in this question. Paternal karyotype analysis could have potentially been helpful for certain genetic conditions. However, congenital hypothyroidism is not something that could have been predicted with paternal karyotype analysis. It's not a genetically inherited condition that we would expect to be picked up on if we were doing parental karyotype analysis. Routine newborn screening, we'll leave that one for now because it's not a prenatal test. Amniocentesis is also a prenatal test that could be done to identify aneuploidies, for example. A congenital hypothyroid does not fit into that category of conditions, so we can cross that off. Prenatal inhibin and prenatal alpha-fetoprotein. So these are both part of the non-invasive routine screening that's done in the first trimester and second trimester. So inhibin is part of the quad screen. Alpha-fetoprotein is done in the first trimester. And so these are useful, for example, for aneuploidies for inhibin level or neurotube defects for alpha-fetoprotein. But again, none of these pick up on congenital hypothyroidism. So we can cross those off. And then finally, maternal RPR testing. If you were thinking that potentially this sounded like a congenital infection because of the jaundice and some of the other features, you weren't sure that exactly what this corresponded to, and you were maybe thinking congenital infection, this could have been a red herring here. This would pick up on whether the mother had syphilis, and so if we were concerned about congenital syphilis, but that presentation is not at all consistent with this constellation of symptoms. And so if you don't remember, the presentation for congenital syphilis, also really important to be able to pick up on that, but it's very different from the presentation here. So that one was wrong. So that leaves us with routine newborn screening, which is the correct answer. So all of these screening tests that we are potentially concerned that maybe the mother didn't get all of these tests. So that's why this question is a little bit tricky, because we're not given information about the mother's prenatal history, but none of these prenatal screens could predict congenital hypothyroid. This is something that is screened for in all states in the United States on the newborn screen. And so when we're told that the infant was born at home, this is giving us a clue that the newborn maybe didn't receive all the newborn healthcare maintenance things, like the newborn screen, which is done at 24 hours of life typically, the hepatitis B vaccine, vitamin K injections to prevent bleeding, erythromycin eye ointment to prevent neonatal conjunctivitis. So all those things are part of routine newborn care in the hospital. And so the fact that the baby was born at home was a clue that maybe they did not receive this newborn screen. So let's take a few minutes to review congenital hypothyroid, because although it is a slightly more challenging diagnosis to make, it certainly has the potential to pop up on both your PEDS shelf and your Step 2 CK exam. And it's really important to be able to recognize it, because this is a totally treatable condition, and it's could be predicted by the newborn screen. And that's why the newborn screen is so important, because it can pick up on conditions that are treatable in newborns. All right, so let's keep reading. Etiology of congenital hypothyroidism. So most commonly, this is due to thyroid dysgenesis, less commonly due to inborn errors in thyroid hormone synthesis. This will present with a constellation of findings, some of which are non-specific findings that we would expect to see in pediatric congenital syndromes, and some are more specific to thyroid. So the majority of infants are asymptomatic at birth, and that's because some maternal thyroid hormone crosses the placenta. And so this might not present in the first few days of life. It typically presents in the first few weeks to months of life as those maternal thyroid hormone levels decrease. So typically we'll see either all or some of these features, including lethargy, hypotonia, feeding problems. Often the infant needs to be awakened to nurse, doesn't wake up by himself or herself every 2 to 3 hours. The features that are really specific for congenital hypothyroidism are the ones I mentioned already. So the hoarse cry, the macroglossia, large fontanels, prolonged jaundice, and umbilical hernia. If you see a few of these are major clues, and after this question, you'll be able to recognize these as being characteristic features of congenital hypothyroidism. So you don't need all of these. I would just say if you see even 2, 3 of these, certainly even only 2 of these, you should have a high index of suspicion for congenital hypothyroid. Other features make sense because they're consistent with hypothyroidism in general, and they're features that you would expect to see in hypothyroidism in older children or adults. And so we also see some of these in children, including dry skin. The puffy face was the myxedema that can lead to puffy face, constipation, hypothermia. So those are consistent with decreased thyroid hormone levels, but they're not necessarily specific to congenital hypothyroid. So the ones that are really specific to congenital hypothyroid are the ones that I'm pointing out here with the arrow. The birth length and the weight are typically normal, although the birth weight can be a little bit high because of the myxedema, and the head circumference tends to be increased because of this facial puffiness and facial myxedema. To make the diagnosis, it's the same criteria that you would use for adult hypothyroidism, so elevated TSH and low free T4. And this is part of the newborn screen in all states. And that's because if untreated, this can lead to a lot of complications and has a poor prognosis, but it is completely treatable with levothyroxine, as we would treat older children and adults who have hypothyroidism. So it's part of the routine newborn screen in all states, and it would have predicted this patient's presentation if the newborn screen had been done when the baby was born. And so important to know that this is treatable with levothyroxine, and to be able to pick up on this presentation, and always look out for some clue about how the infant maybe didn't get the newborn screen or was born in a different country, so you don't have the baby's prenatal history and newborn history. You're not sure exactly what type of interventions were done in the location where the baby was born. So look for that type of clue in the question stem for a question about congenital hypothyroidism. So that wraps up our question of the week. Thanks so much for listening.